Hi, good morning, everyone. We are yet again live on 165th CMAAO weekly session. We are joining in on every Saturday, 9:30 a.m. I would like to make this session, if anybody wants to come and join and ask this session, ask questions in this session, they can join in on the Zoom meeting at 8188591157, and you can write your questions in the chat box over here. I repeat, 8188591157. We have a very, very important speaker on a very, very important topic. The topic is atrial septal defect. It's a hole in the heart between the upper chamber. I would like to invite Dr. Monica Vasudev to invite the speaker who is joining in, especially from US. Dr. Monica, over to you.
Thank you, Saurabh, and thank you to CMAAO platform. And it is my pleasure today to introduce Dr. I.B. Vijayalakshmi to today's platform and to share her esteemed knowledge with this group today. So Dr. Vijayalakshmi is a distinguished figure in the medical field, known as the first lady cardiologist and the first pediatric cardiologist in Karnataka. She is a pioneer in pediatric cardiology interventions with over 9,000 catheterizations to her credit. Now, this is a procedure very common in adults, not very common in children, and has its own unique set of challenges in children. And to have that type of legacy of 9,000 procedures is incredible. It really speaks to her experience and her knowledge and patients' trust. Dr. Vijayalakshmi holds numerous accolades, including 38 gold medals, 2 silver medals, and 60 prestigious awards. Her impressive academic career is complemented by 156 research papers, 58 of which are international, and 4 textbooks for cardiologists. To publish in this type of arena means that your work is peer-reviewed. You take your work, you publish it in a way that can be understood by other people, and you're not only vetted on the quality of your research, but you're vetted on what type of message you are presenting to the scientific and medical community. For your publication to be accepted into the international arena like this speaks to the international caliber of Dr. Vijayalakshmi. Notably, she is the only Indian to deliver multiple lectures at the World Congress of Pediatric Cardiology in 2013. I have merely scratched the surface of an incredible career of an incredible woman in medicine who is helping women and their children, especially with cardiac disease. And I pass now the floor to you to share your knowledge. Thank you.
Thank you so much, Monica, for the wonderful words and very kind words. You have made my day. You have made me so happy today with your such a good intro. So can I share my slides now?
Absolutely, ma'am. You can.
Yeah.
From yours.
It's my great pleasure today. Good morning, good afternoon, and good night to all the people here. So, atrial septal defect, I'm going to speak at the 156th International Weekly Meeting of Heart Care Foundation of India 2023. It's my pleasure to meet you all. Friends, the atrial septal defect, in short called as ASD, is a hole in the septum between the 2 atria, causing the left-right shunt, leading to the increase in the amount of blood that flows through the pulmonary artery and in turn into the lungs. The atrial septal defect is present at birth, hence it is called as the congenital heart defect. And as the left shunt is from the left-right, there is no cyanosis, so it is the commonest acyanotic congenital heart disease. ASD is present approximately in 4 to 8 out of every 1,000 babies born, and the size varies from small to the very large. Now, coming to the types of the atrial septal defects, one should know that ostium primum ASD is the one And this is in the center of the septum, and this is the commonest one. Ostium primum AST is just above the tricuspid valve, and this is most often seen in the Down syndrome or the AV canal defect. The sinus venosus type of AST is just below the superior vena cava or just above the inferior vena cava, and it is called as the sinus venosus type of AST. And almost 80% of them, they have the associated partially connected pulmonary artery venous connection. That is called as a PA-PVC. And the rarest of the rare is the coronary sinus, where the coronary sinus opens into the right atrium. The roof is absent, and that is called as the unroofed coronary sinus, and that is the rarest of the types of atrial septal defects. Now, coming to the incidences, ostium secundum AST is in the center, and this one is almost forms the 75% of the ASTs. Ostium primum is just at the inlet, just above the tricuspid valve, and this is about 15% seen in the AV canal defect, either partial or the complete AV canal defect. And then the sinus venosus type is the SVC type or the IVC type are about 10%. And unroofed coronary sinus is less than 0.1%, and hence the incidence is extremely rare. Atrial septal defects might be found by chance in the echo. Most often when the baby has got respiratory distress, the pediatricians ask for an echo, and when the echo is found that there is a small AST, the whole family becomes panicky. But no, that respiratory distress may be due to the respiratory lung problem, premature lung, or something else rather than the small AST. Because these small ASTs, which are found in the infancy, they close as the child grows up to 1 year or 2 years, and hence nothing to worry at all. A large AST can dilate the right atrium, right ventricle, pulmonary artery over a long time. And over the period after 20, 30 years, when the person is about 30, 40 years old, and at that time the pulmonary artery hypertension occurs, because of the right atrium enlargement, there can be arrhythmias, atrial fibrillation, atrial flutter, because SA node is in the right atrium. Surgery may be needed to repair the atrial septal defect before the child goes to the school. Much better is the device closure to prevent the complication later on in life. And here you can see that the AST may go unrecognized for many years or even decades, because the symptoms are so flimsy that it's just like a cough or a cold or repeated respiratory infections with very minor thing. And as a result, most of the parents neglect it. And more so, there is a soft mid-systolic murmur in the pulmonary area, which is mistaken as an innocent murmur or a functional murmur. And again, it is missed. And sometimes for something else, the patient would have gone. When they take the X-ray, they find the cardiomegaly, and then they suspect there is something, and then they send to the doctors. In contrast, ostium primum AST is usually very large, often presents in infancy with the pulmonary artery hypertension, with the intractable congestive cardiac failure, and especially when there is a single atrium or a large AST, then they present very early in life. Otherwise, most of them, they present much later. And here, it is very important that the pediatrician should know the signs and symptoms of atrial septal defect. Shortness of breath, fatigue, especially on exercising, swelling of the feet and the abdomen, palpitation or the skipped beats, the person knowing about his heartbeats, and then the atrial fibrillation or the missed beats can be felt as the palpitation. And on auscultation with the stethoscope, there is a very soft, superficial grade 2/6 ejection systolic murmur, which is heard with in the second intercostal space. Invariably, unless the whole clinic is very silent and there is no noise, this murmur may be missed by the clinician. And more so because The auscultation is a dying art, and nowadays hardly people are using their stethoscope for the detection of the murmurs. And what is more important is in this condition, the second sound is split and it is fixed. And that is the hallmark of AST. A soft, superficial, grade 2/6 ejection systolic murmur with the split second sound, which is widely split and then it is fixed. And one should not miss that. In 1925, when William Osler used to teach the students, he used to teach about the inspection, looking tangentially, then palpation with the palm and the hand straight, and then auscultation and sitting by the side for the contemplation. And in those days, these 4 points used to be the compass for the medical students. So they used to give lots of importance for the inspection, palpation, auscultation, and contemplation. But today, everything goes wrong. Why do we go wrong? Because common sense has become uncommon. Clinical logic is lost. And then accurate observations are no observations. And there is no time for the person to contemplate and sit what is correct. And straight away, they send the patient for the echocardiography or the X-ray. And here, friends, you must remember that today, ECG, X-ray, echo, angio are the 4 points for the cardiologist's compass to make the diagnosis. But however, clinicians, if they are very good in clinical acumen, and they can make the diagnosis of AST very well with the soft murmur and detecting the split second sound. Now, ECG, coming to that, invariably there is a sinus rhythm, unless they are in atrial fibrillation. Then there is a prolonged PR interval, especially in a Holt-Oram syndrome. There is a first degree AV block. There is sinus bradycardia and ectopic rhythm causing either atrial fibrillation or atrial flutter. In sinus venosus type, the P-axis is leftward and with the inversion of the inferior leads and upright in the AVL due to the ectopic pacemaker. Distinct right axis deviation is seen. RS-R' pattern is the hallmark of AST in the precordial leads, and RS-R', that is a capital R with the dash in V1 with V2, indicates that this is of a long duration and the pulmonary hypertension has occurred. Though the QRS is wide, we are not going to call it as the bundle branch block, because calling right bundle branch block is inappropriate and incorrect. It is not bundle branch block. The pattern sequentially changes from RS-R' to RS-R' to RR and then ultimately R. And when the Q waves occurs, that is a suprasystemic RV pressures are there. And hence, it is very important to find out the patient when they are in the RS-R' pattern rather than the RR with the QR complexes. Now, here you can see that it's a sinus rhythm and there is a RS-R' pattern. The small R, S, and then R' pattern is there. This is the classical picture of the atrial septal defect. Once the patient goes into hypertension, that is the pulmonary hypertension, and then instead of RS-R' pattern, you have R and R'. And this capital R with the number of this thing in the R', we can make out how much the pulmonary hypertension is there. And a small R is replaced by the peaked P wave or the P pulmonary, and this indicates that there is a pulmonary hypertension. So this is how we detect the pulmonary hypertension in RS-R' pattern. And if you take the natural history of the atrial septal defect, right ventricular dilatation, that is the at the base, and then the pulmonary hypertension causing the pulmonary artery aneurysmally dilated. Here you can see that the main pulmonary artery is aneurysmally dilated and the right pulmonary artery is also dilated, almost like a kettle it's looking. And they here, apart from that, atrial flutter, atrial fibrillation, and then the paradoxical embolism, the clot from the limbs can go through the AST to the left side, and they can have almost like a pulmonary edema. And this is how we have to see that atrial septal defect. This is how the pediatric cardiologist, we invert the image and do the echo so that, it is almost like the anatomical picture of the heart. And this is what the cardiac surgeon also like it because it is easy for them. So here you can see that this is the right atrium and that is the left atrium. And in between the septum, you can see that there is a hole. So this hole can be precisely measured and diagnosed by putting the color Doppler. So here you can see that the color Doppler is showing there is the left to right shunt. The blood is arising from the left atrium to the right ventricle. And as a result, this is a large ostium secundum AST in this patient. Now, echo helps us to not only make the diagnosis, decide how to close it. And here you can see that in this patient, there is a closure of the AST is done by the device. So this is how echo helps in making the diagnosis, management, and post-procedure, how to evaluate. Thanks to Dr. Kurt Amplatz, he is the one, a great guy. And in Minnesota, where I was trained, he came out with the Amplatzer device. And this is how, this is the nitinol wire mesh connected by a vase with the corresponding to the size of the AST. And this is the lady who's stitching in the factory the polyester material inside the nitinol mesh. And this was the first FDA approved user-friendly device, which is with a high success rate, almost 99.9% success rate. And as a result, we have now started using the Amplatzer device for closing the atrial septal defect. Now, the non-surgical device closure has revolutionized the management of AST with a very high success rate. Then the question comes, can we all close all the ASTs? The answer is no, not all can be closed with the device because unless it is an ostium secundum AST and then suitable, we cannot. So this raises the question, which are the ASTs that can be closed with the device? Which are the ASTs that cannot be closed or should not be closed by the device, and why? If closed with the device, what happens? So echo is the best tool to give answer for all these questions. Now here you can see that this is the ostium secundum AST, almost 75% as I told. Ostium primum AST is 15% and sinus venosus type AST 10%, and I have already told. But when these ASTs are associated with the PAPVC or the total anomalous pulmonary venous connection or associated VST or complete AV canal defect, as in the AV canal defect, and it is the another AST is there, these are the patients who go for the surgery. However, if the patient has got AST with the mitral stenosis, which we call it as a Lutem-Bascher syndrome that we see in the adult. Rheumatic heart disease is very common in the Indian subcontinent, that is Pakistan, India, Bangladesh, Nepal, Sri Lanka, the whole subcontinent. Rheumatic heart disease is common. So a congenital heart disease AST can be associated with the mitral stenosis, and that is called as the Lutem-Bascher syndrome. AST with the pulmonary stenosis called as the triology of Fallot, and AST with the PDA or VST can all be closed with the device, and the pulmonary stenosis can be opened. Mitral stenosis can be opened by the balloon. So not necessarily that all the associated lesions, when they have to go for the surgery. Only TAPVC, PAPVC, AV canal defect, they go for the surgery. But if there is associated mitral stenosis, pulmonary stenosis, PDA, VST, they all can be closed with the device at the same time. Here you can see that this patient has got both AST and the VST, and I have closed both simultaneously. And thanks to the device closure that we can tackle in the same sitting with the femoral artery puncture, and then we can do. So in the cath lab, the echo technician will be guiding us, and the sisters and the cath lab technicians will be guiding us to put the device properly. One has to take care that no air and no clot embolization occurs to get the high success rate. Now, this is the diagrammatic picture of how AST is closed. So here you can see that this is the partition, and then the hole, and then our catheter goes through the hole, and we put the guide wire and go to the left atrium and anchor it in the left pulmonary vein or the upper pulmonary vein. And then the device is released. Only the left disc is released in the left atrium and pulled it up to approximate at the septum. Once it is approximating at the septum, we know that at that time we release the right atrial, the rim. And once the right atrial disc is released, we put a Minnesota wriggle, just pull it a bit like this, and then see that it is snugly fitting and it is not loose, and then everything is fine. And then we do the anti-clockwise rotation at the outside, and then the screw which was fixing to the device is opened, and as a result, the device sits exactly across the septum, the superior septum and the inferior septum here. So here you can see that I'm loading the device into the loader and then releasing the disc up in the left pulmonary vein, and then the right one, and then a Minnesota wriggle pulling, and then screw is removed. And this is how the AST device closure is done. Now, this is a 50-year-old male, known case of AST in childhood, but said to have closed in the adulthood. And they said that don't worry, it will close. And recently, the patient came with the louder murmur, and there was a mild cyanosis and clubbing. So the treating clinicians got worried, and then they sent the patient to me. And surprisingly, there was a grade 3/6 ejection systolic murmur, split second sound was there, P2 was normal, and echo showed a gradient of pulmonary stenosis, 45 millimeters of mercury. Now, is it the AST with the pulmonary stenosis, or what it is? Why the patient has developed cyanosis? And because the treating clinician, they said that because there is a cyanosis and he is inoperable and he has gone beyond the stage of operation. When I did the echo, I was surprised to see that there is a sinus venosus type of AST. You can see that it is just below the superior vena cava, and the septum, there is a gap, and this is the AST. And what you see is the SVC is straddling. It is straddling over the septum, and as a result, the desaturated blood from the superior vena cava was coming into the LA, causing the cyanosis and the clubbing. And this is, the misdiagnosis. Had I not done the echo properly and then the T, then I would have missed the diagnosis. And like other people, we would have said, oh, it is inoperable, and the patient would have sent back. But fortunately, this patient underwent surgery, and now he's doing absolutely well. 10 years back, he was operated, and now he's all right, though he's beyond 60 years. This is another case, 55-year-old lady, my daughter's roommate's mother, working in the bank. She had breathlessness and swelling in the lower limbs. And because she was diabetic for 15 years, the clinician made it as a diabetic cardiomyopathy and the nephropathy. And they said that because the patient has got a pitting edema, they have to go for the renal transplant or something. And the whole family was so devastated and worried. And then my daughter rang me up. When I auscultated her, there was a ejection systolic murmur, grade 2/6, and the wide split second sound. I said, yeah, here, this is the AST. And when we did the echo, you can see that the patient ECG showed the RSR- pattern and the patient was fine, and a large AST was there. Almost 30 millimeter AST was there in the T with the left-right shunt. And then remember, only right atrium, right ventricular dilatation is not a hallmark of diabetic cardiomyopathy. Diabetic cardiomyopathy involves the left ventricle also. So here the clinician should realize that if there is a only right to left, right atrium and right ventricular dilatation, that is more in favor of the AST. And ultimately, I closed it with the 32 millimeter device. And here you can see that the device is sitting very pretty. And then the patient's X-ray, which was like this, became like this the moment I closed, because there was no pulmonary hypertension. It was more of a pulmonary congestion rather than the pulmonary hypertension. And as a result, after almost 15 years, they are absolutely fine. And they treat me like a goddess because the patient is absolutely fine. So remember, the normal JVP, no systolic thrill. If there is a systolic thrill, that means there is an associated pulmonary stenosis or there is a large shunt. And then mid-systolic tricuspid flow, also murmur can be there, indicating that there is a large shunt. So apart from that, sometimes we can have an inverted P wave in the sinus venosus type of ESC. So here you can see that the P wave is inverted and the axis is inferiorward. And this happens when there is a sinus venosus type of AST with the PA-PVC. So this is the sinus venosus type of AST with the PA-PVC with the pulmonary hypertension, and this requires early surgery. And this is a 22 years old lady diagnosed as mitral stenosis 2 years back. And then, she had a narrow pulse and the MDM, and then she was sent. But there was a fixed second sound. P2 was loud. And when I did the echo, I could see that there was a membrane in the left atrium. And apart from that, there is an AST. So along with the AST, there was a membrane. It is called as the quadriatrium sinister or the divided left atrium. So this patient was sent for the surgery, the surgical closure, as well as the resection of the excision of the membrane. Now coming to the Lupton-Baxter syndrome, it is quite common in the Indian subcontinent. In our country, very often we have the rare combination of CHD as well as the AST, and also the most common acquired rheumatic heart disease, that is the mitral stenosis. So AST is the commonest congenital, mitral stenosis is the commonest RHD, and the combination of the two is almost incidence is 4%, and the incidence of AST in mitral stenosis is just 0.6%. So auscultatory yields better when you put the patient in the left lateral position and with the bell and make the person exercise and then auscultate, you can hear the mid-diastolic murmur. Otherwise, because of AST, there is a RA-RV dilatation, and then the mid-diastolic murmur of the MS can be missed if you don't put the patient in the left lateral position and then auscultate at the mitral area or the just proximal to the apical impulse. Now, what is the effect of mitral stenosis on the AST? And here you can see that because of the mitral stenosis, the blood is not able to flow into the left atrium. So most of it comes to through the AST into the right atrium. So the shunt is increased and the patient develops pulmonary hypertension much earlier. Incidence of bacterial endocarditis also increased. Actually, the bacterial endocarditis in AST is rare, but if it is associated with mitral stenosis or rheumatic heart disease, then it is more common. Increased incidence of atrial fibrillation, right ventricular failure is much more, and evidence of RVH in ECG is more common than uncomplicated simple AST. Now, friends, what is the effect of the AST on the mitral stenosis? Because there is a easy event, the symptoms of mitral stenosis like orthopnea, pulmonary edema, or paroxysmal nocturnal dyspneas are all reduced in case of mitral stenosis with the AST. So because of the easy bend, the pulmonary edema does not occur, the pulmonary venous congestion does not occur. So the paroxysmal nocturnal dyspnea called as P&D are not there. So it decreases the cardiac output. Gradient across the mitral valve is reduced because easily blood is going into the right atrium through the AST. And X-ray exhibits increased pulmonary arterial blood flow and what is called as the pulmonary plethora or without any pulmonary venous congestion. So this is the effect. And this is the post-op residual AST. The patient had already undergone surgery. And here you can see that this is the patch and the patch is given up and then there is a residual AST in the post-operative period. And the transesophageal echocardiography is very, very handy because especially in the older patient, the transthoracic pictures are not clear. So when we do the transesophageal echocardiography, we can see it very clearly. Now, as on today, net left-right shunt of QPQS more than 1.5, they all go for the either surgical or device closure or patient with the severe irreversible pulmonary artery hypertension and no evidence of left-right shunt, and they are treated medically and no surgery or no AST device closure is done. This is according to the American Heart Association. Here I'm showing you an example of 42 years old man who came with the palpitation and breathlessness and fatigue. And in the MOD, you can see that there is a huge right ventricle. It is double the size of the left ventricle. And there is a paradoxical septal movement. And what is important is the pulmonary artery is almost double the size of aorta. This is the aorta and this is the pulmonary artery, almost double the size. And here you can see that the RA, RV are dilated and the RV dysfunction is there. So this is inoperable. In contrast, the person with the pulmonary valve stenosis, the lungs are protected. And as a result, though there is an AST, instead of developing pulmonary hypertension, they develop right to left shunt and then they cause the cyanosis. And here, one may think that the cyanosis is due to the Eisenmengers and they say that it is inoperable. But clinically, you must auscultate. If P2 is soft, it is pulmonary stenosis. If P2 is loud, it is the pulmonary hypertension. So clinically, you auscultate and decide whether it is a stenosis or it is the hypertension. Here you can see that in the ECG, you can see that the V1 is so tall and that indicates that there is a pulmonary RV pressures are very high. So RV pressure can be increased when there is a pulmonary stenosis or there could be pulmonary hypertension. And here it's basically because of the associated pulmonary stenosis and the strain pattern is there. So here the pulmonary, this is the echo of the patient with the pulmonary stenosis with the dilatation of the right atrium, right ventricle, tricuspid regurgitation, and with the small AST here. And here, by just opening the pulmonary valve with the balloon dilatation, the patient will do well. If it is a PFO, it will close. If it is a small AST, nothing to worry. If the AST is larger, we can close it with the device. So the triology can be easily treated. But however, before we venture for closing the atrial septal defect, we must look at the rims all around. And unless the rims are adequate and more than 7 millimeter is there, then we cannot. So many a times the aortic rim may be deficient and the central defect will be more bigger. And here when the inferior vena cava rim is very less and that is unsuitable for the device closure. So in the subcostal view, we measure not only the whole of the intraatrial septum, the AST, and then the inferior rim and the superior rim, and all are measured. And here one should remember that the AST device has got a 7 millimeter rim all around. That means 14 millimeter is to be added to the size of the AST. So if the waist is 14 millimeters, we have to add another 14 millimeters, and that becomes the 28 millimeter. So unless we have the intraatrial septum of 28, we cannot put the 14 millimeter device. And while measuring, we have to have the proper picture of the echo, otherwise we will be going wrong. And the AST has to be measured in not 1 or 2, 3 views. And then there is what is called as the T sign, where the tip is hyperechogenic and we measure the size precisely. And this is the subcostal bicable view. There is the inferior vena cava. So inferior vena cava is guarded by the eustachian valve. And in the past, many people who are not used to it, they used to mistake this as the septum. And I have seen a cardiac surgeon committing blunder by stitching the eustachian valve to the proximal rim of the AST. So that should not happen. So this is the atrial septal rim, and that is the eustachian valve. And one should be very careful in making the diagnosis. So here the transesophageal echocardiography, you can see that posterior superior rim is absent, and hence this is not suitable. This is another TE. Here you can see that this is the aorta, and the aortic rim is hardly 2 to 3 millimeter. Unless we have 4 millimeter aortic rim, we are not going to put the device. Otherwise, if we oversize the device, and then there will be erosion. Till today, I have done thousands of cases. Not a single patient has gone for the erosion. But this is the Western literature where they have shown that ambulatory device appears to occur only once or twice per 1,000 device patients. And this erosion is more common in the Western literature where they oversize by the fear of the device embolizing. So here you can see that this is the diagrammatic picture. If you oversize, the rim will be impinging on the aorta, and with every beat it goes on poking, and that will cause the erosion. And this has to be avoided. And if the intra-atrial septum is not strong, and then it will start wobbling. And in the screening, you should not get scared that, oh, something has gone wrong and the device is wobbling. No, it is because the strength in the intra-atrial septum is not adequate. So the echo can measure the length of the septum, but not the strength of the septum. So due to the fear of embolization, many people oversize the device by 3 millimeter, 4 millimeter. That means if they have got 16 millimeter AST, they will take 20 millimeters of device. And that time what happens, the intra-atrial septum is not adequate. The device will crump like this, and then it will look like a oversized one. Whereas the correct size device will look like this, absolutely flat, almost closing the septum, approximating properly. So this is how the oversizing or the right sizing have to be seen. And the deformed device indicates that you have oversized. And many a times you get a tiny residual AST because AST is not an oval structure. It is not a round structure. It may be round, it may be small. And when it is oval and our device, which is a round one, and it sits like this, and then by the side, there may be a residual shunt. And hence today, instead of depending on just 2D echo, we depend on the 4D echo. The advantage of 4D echo is we can see the AST from the right atrial side, we can see it from the left atrial side, and as a result, our device closure is much better when we do the 4D echo and assess. So 4D echo helps us to make the precise diagnosis, measure the precise size of the AST, and then put the device. Not only that, here you can see that in the 2D echo, you feel that the inferior rim is tilting. But then when we did the 4D echo, you can see that the rim is exactly in between the two discs. And this is how the 4D echo helps us to see whether there is a residual one or not. Apart from that, this is the autopsy in the animal, experimental animal, where you can see that the endothelium is growing over the device. But here, after 3 months, in the echo, you can see that in the 4D echo, the whole device is covered by the endothelium, and beautifully you can see that the device has become one with the septum, and then you can make out only because of the color. Otherwise, it is on par with the device. And this is how 3 months post device closure, you can literally see that there is no clot, there is no thing, and then absolutely there is an endothelium grown, so you can stop giving the antiplatelet cells. Otherwise, in the past, the bigger device, we used to give antiplatelets for the almost for 1 year or 6 months. But today, no more. We do the 4D echo and we decide that no antiplatelets are required as the endothelium has grown well. And here you can see that there are two ASTs, one here and one there. And in between rim, if it is quite long, then we'll have to sandwich the two devices in between. So one smaller one sandwiched in the bigger one like this and cover. This is the smaller one and this is the bigger one. And this is how it looks in the fluoroscopy. But suppose there is a very tiny tissue, we just break it open and put the device in that. Now, technical challenges are when there is a very large AST, and I have closed as bigger as with the 42 millimeter device, custom-made device was used in that. So whenever there is an AST, rims are deficient, we just avoid it. And if the patient is less than 5 kilos, we don't. And if there is what to call Chiari network or the septal aneurysm, and this is in patient of tricuspid atresia, this AST goes for the surgical closure along with the correction of the intracardiac thing. And apart from that, we have to have a sheath which is properly alienating, and the echo is the best tool to decide whether the device is properly sitting or it is wobbling or it is displaced or it is dislodged. And all these things can be made out. And here you can see that we have catheterized, the device is put, and before it could be released, it has come into the right atrium, and then that device is caught with the snare and pulled into the sheath. And this is how you can see that it is being pulled out. So one should know what you put inside, should be able to pull it out as well. Now, echo is the percutaneous closure is very important. And here, this is the 45 years old patient who had cyanosis, hypoxemia, platypnea, orthodoxia, and this patient we closed with the PFO closure, and then the patient became all right. So patient with the defects of more than 36 millimeter, we have to have the bigger devices. If otherwise, we have to avoid it. Otherwise, they'll have erosion and embolization. Any small AST less than 10 millimeter, hemodynamically insignificant, we are not going to close. Just because there is a hole, you should not close. Severe irreversible pulmonary artery hypertension, color Doppler shows this thing, and then we have to do the cath, calculate the PVRI, and then decide. If there is a ostium primum AST, sinus venosus type AST on the echo, they go for the surgery. So this is how you can see that there is a very large AST and it is almost 39 millimeter. Hardly any rims are there. So that goes for the surgical closure. And this is the fenestrated ASTs. Multiple ASTs are there, and in between rim is not there. And this patient requires 2 ASTs. And here you can see that either that little tissue can be broken, made into single one like this, and a single device can be put to save the money. So friends, technique can be difficult with the deficient rims, but however, as we become more and more experts, the more and more difficult cases can be taken up, and then we can get excellent result. And Dr. Bharat Dalvi from Mumbai has come out with the balloon assisted technique, and that is called as the BAT. Now the cricket tournament, world tournament is a championship is going on in India, and everybody is interested in the bat and the ball. And here you can see that this is the balloon assisted technique called as the BAT. And with that, we can complete the device. And now we have intracardiac echo called as the ICE. And with that, we get the very clear pictures. We can do a wonderful job. And literally, we can see how much the defect is there, how our device is sitting. And then this is the catheter for the ICE. And this is how the intracardiac echo helps us to make the diagnosis. So this is the balloon-assisted technique. And today you must remember that deficiency of the any rims, we should not go. And very important point is whenever the AST is closed, there should not be any thrombus either during the procedure or later on. So to prevent that, we put the patient on the clopidogrel or the aspirin for almost 1 week before and then afterwards. And otherwise, this was one of my patients, the only one patient who had a hypercoagulative syndrome. And as a result, multiple clots were there and the patient went on embolizing and having convulsions. Otherwise, we had absolutely good results. And sometimes what happens is when we are cramping the device into the sheath, it may become like a cobra and then it may get deformed. And at that time, we should pull it back and then make it proper. And then again, through a bigger sheath, we have to put the device. So the deformity also has to be seen. So friends, coming to the natural history of the AST, chronic right and the ventricle and the right atrial dilatation can occur. Long-term complications are life-threatening, atrial fibrillation, thromboembolism, and then the patient may die of the pulmonary artery hypertension. And when I did the comparative study published in our Indian Heart Journal, you can see that 6,700 patients in India, we compared with all the countries elsewhere, and you can see that atrial septal defect is the commonest one. And in our country, marriages are made in heaven. So the consanguineous marriages, arranged marriages lead to the increased incidence of AST. But thank God that this AST is very simple and it can be treated very well, unlike the complex congenital heart disease. So to conclude, non-surgical transcatheter device closure has revolutionized the management of ostium secundum AST. It is very attractive alternative to the surgery. Thanks to the excellent evaluation by the echo, transthoracic, transesophageal, intracardiac echo, today we can get the highly successful rate, and the complications can be avoided by like erosion and other things. And so friends, in the past, the ugly scar with the keloids used to be like this after the AST closure. Now just 2 millimeter nick made to put the catheter, even if the patient wears a bikini, nobody can make out that the patient had a device. So that is the beauty of the device closure. But however, when people get attracted and they try to, with over enthusiasm, they try to do the device closure, their mind is distracted, and you can see what happens. You can have a crash in the cath lab, and to avoid that, you have to be very careful. And this is the picture from the Kuala Lumpur, where I did the device closure in 2002. And at that time in China and Japan, they were not doing the device closures. And then they said that you are the source of inspiration for us. And this is the great guy, Kurt Amplatz, who is who has given the device for us. So friends, atrial septal defect is very common, but nothing to worry. Once I was sitting in a lunch and a lady started grumbling that her brother has been duped because the wife has got, Bhabhi has got a hole in the heart. I said, don't worry, you send her to me, I will make her all right. And then the first device closure of AST that I had done, she scored 96.8 and then got a medical seat in the government medical college. And now she's a practicing doctor. And one patient came for the fetal echocardiography, and her husband started brimming, smiling by looking at me. I asked, what is the matter? He said that, oh, I had not seen you, but my father-in-law had told that you are the one who had closed the hole in my wife's heart. And then he had told, you can go and ask her. And today you are doing the echo for my child to be born, and I'm very happy. So friends, that is the beauty of the atrial septal defect being closed with the device. And thank you very much for your kind and the patient hearing. And I'm here to answer any questions you have. Thank you very much.
For such wonderful the members on the forum for their comments and any questions, please to ask. Please come forward. Dr. Monica, would you like to take it forward?
Sure. That was a fantastic presentation to summarize not only the pathophysiology, the prevalence, how India stands in relation to the rest of the world, to bring in your training from Minnesota to all your experiences around the world and the mentors that you've had, and to talk about device development and how that can revolutionize when things become simplified. Fantastic. It was just incredible.
Thank you so much, Monica. Thank you.
You're welcome. You're welcome. The one question I have is, I'm an allergist immunologist, and in part of our immunology training is we look at primary immune deficiencies.
Yes.
So there are conditions that have congenital heart disease, not so much ASD, maybe more VSD and tetralogy of Fallot, which is what you know where I'm going.
Yeah.
And what is the prevalence, or what is your screening practices for DiGeorge syndrome or 22q11 deletion syndrome or other congenital diseases?
Yeah, very, very important question. So in our country, we have started the fetal medicine in our department. And where I work, Jaideva is a premier institute with the 2,000 beds only for the cardiac patients. And we have 4 centers all around. And it is a dictum to screen the mother as well as the child for any associated genetic problems. So genetic counseling is part and parcel of any pediatric cardiology practice.
Fantastic. So what types of numbers are you seeing for primary immune deficiencies? Are there some of these kids caught early? Are they given IVIG? Are they given any intervention?
No, most of them, they go to the pediatricians, no, unless they have any correction to be done, they don't come to us. So immune deficiency is treated by someone else. That is not my territory. Yeah.
Perfect. Thank you. And then I guess the other question is, while we're waiting for others, is that you talk about your experience with adults as well.
Yes.
So it seems like your experience in pediatric ASD has now crossed over generations.
Yes.
So even it's more like congenital as opposed to pediatric.
Yeah.
Adults with congenital ASD.
Yeah. See, once you start doing for the children, doing for the adults is no problem at all. It is like, drinking water, it becomes much easier. But only problem is in adult, the transthoracic echo is not good. We have to do the transesophageal. And at that time, the picture is better, but the transesophageal probe comes exactly over where our device is coming. So we have to go to the pulmonary vein and then do it. And when I was doing the workshop in teaching the people in Tirupati Medical College, and I put the 42 millimeter device in an adult patient. And this is how we can go beyond. But then, teaching is something, but when it comes to practically, better not take the risk because they can go for the erosion and all sorts of problems. But then, of course, the sky is the limit. Once you have the skill and the will, you can do anything.
Yes. Yes. Well said. Thank you very much.
Thank you.
Hi, good morning, everyone. It was a really excellent presentation. I'm Dr. Hussain from Durban, South Africa. I was just thinking, VSD and other septal defect, are you also doing in utero before the baby born? And how is the results?
No, sir. We don't do the device closure in unborn babies. Only if there is a aortic stenosis or pulmonary stenosis, causing hydros fetalis. To save the baby and prevent the stillbirth, we can do the balloon dilatation. And this was started by this is in the Boston children. And after that, even in India, in Hyderabad and in Delhi, Mumbai, they are doing. But this is only to prevent. But what I have done is, soon after the birth, within 14 hours, I have done the balloon dilatation in the hydros fetalis. The child was brought on the ventilator, and then, crossing the pinpoint aortic stenosis and opening with the coronary balloon, just 4 millimeter balloon. And now the child is almost 15 years old and very mischievous and very, very nice baby. So this is only the blockages can be opened in the valves in the intrauterine life, but the device closures is done only after the birth.
No,
and
thank you
now,
so much.
now in the premature babies, even 800 grams or 1000 grams, if the PDA is there, that has been closed with the Piccolo device. So that is done only for the PDA if the child is not thriving and going to failure. But ASTs, by and large, we don't close in the after birth. We wait for 1 to 2 years and then close.
No, thank you so much. Excellent
Thank
work you do. Thank you.
Can you ask a question?
Yeah, Surab, can I? Surab.
Absolutely, please go ahead.
So yes, this is Dr. Kaisar Sajjad. Actually, I'm sorry I have joined late, but I'm lucky to join today's webinar of CMAAO of a very smart and beautiful expert and competent lady. So I'm very much lucky to attend today's meeting because I have missed 2-3 previous meetings. So it was a fantastic. I am an ENT surgeon, although I'm an ENT surgeon, but this is a revision of my MBBS teaching, which I have learned in the MBBS. So, but I have a question in my mind that at what range of age you do this device applications, and what is the percentage of recovery, the result, and the positive cases of percentage of cases, successful cases. Thank you very much.
Thank you, Kaisar sir. Thanks for the lovely compliment. I think after Monica, you have made my day today, calling me as the beauty and the brain. And thank you very much. See, now we always do in the preschool age. That means when the child is 3 years, 4 years, and that is the time we closed with the device. And then age is not a limit, but before below 25 kilos, we hardly do it because it is not required. The child is not testing. Unlike the PDA and the VST, the child does not develop pulmonary hypertension in ostium secundum VST. So the ideal time is just before the child joins the school. That is the ideal time. The success rate is 99.99% because you are assessing properly, taking the proper device, and then putting it properly. And once the device is there, the endothelium grows on either side and it becomes part of the septum. And as a result, it's so beautifully the patient recovers that nobody can make out. And that's why I told you, my patients have become doctors, engineers, chartered accountants, and even the beauty contest, the models. And then when they come and meet me, it is such a pleasure. This is a real marvelous, like a magic that we can give a complete whole normal life to the child.
Okay, one more question. You are practicing in Kerala, okay, or
no, in Karnataka, Bengaluru.
Karnataka. Yeah. Okay. So how much you charge? This is this all procedure or surgery or putting the device?
Okay, in 1998, when I started this, and Kurt Amplatz, who produced this device at that time, nobody was doing all over the world. and he was ready to give us for just 20,000 rupees, 27,000 rupees. And still our professors, they said, though it is too expensive, because they were doing surgical closure for 25,000. This is about 23 years or 25 years ago. But today, the cost of the device is around 1 lakh. And then the procedure charge together, it becomes 1.34 or 1.4 lakhs.
Okay, so how much is in dollar, US dollar, if you convert?
I think Saurabh has to do that. But in our country, we have in Karnataka, we have a facility. Like in our country, our Prime Minister has come out with that Arogya Bharati scheme, where all these things are done free of cost for all the school children. So there is not a problem at all.
Oh, very good.
Every child gets the best treatment because the government pays for the expenses.
For the expenses. Yes, very good. Well done. Thank you very much. Thank you very much. Can't hear you. Unmute, Saurabh. Sorry, can't. Sorry, yes, go ahead.
Cost of 2.5 as a total, which is like $3,500.
$3.5 US dollar. Oh, it's nothing. But the most important thing is that government is not charging any rupee, any taka, rather I can say, what it is.
Yes, sir.
Right.
Yes, sir.
Thank you very much.
Sir, the children are the most precious ones. They are the future of our country. So we have to give the best to them. And that's how we know we don't charge.
Very good, very good. Thank you very much. And hello, everybody. With permission of Saurabh, can I leave because I have to go for my academic?
Thanks for joining in, Dr. Sajjad. We'll see you again next week.
Thank you very much, everybody. Thank you, Monica. Thank you.
So do we have any other questions on the floor from other people? Other members, please come forward. I think it was so well explained session. So we don't expect too many questions, but I see a lot of new faces as well. Please come forward, and if anybody has a question, otherwise we will let ma'am go. I think she has missed her walk due to this session, her morning walk.
Saurabh, I have invited one of my pediatric professor from Pakistan. I hope Professor Naqvi can give the comments. Professor Naqvi, Saima Batul is one of the busiest pediatrician in Pakistan.
Dr. Naqvi, can you unmute yourself?
Yes, Assalamu alaikum. Hi to everyone. I have been listening to your talk. In Pakistan, mostly there are very few pediatric cardiologists at the moment, and maybe only 10 or 12 cardiac surgeons. So ASD being a relatively asymptomatic disease is mostly not picked up in time.
Yes.
But we are catching up because many people are now entering into the subspecialty of pediatrics cardiology now. So the things are getting better, but still there are problems with the treatment because in the far-flung areas of certain districts, especially related to the Khyber Pakhtunkhwa, KPK, and Gilgit-Baltistan, there are no specialized pediatric cardiologists over there. But what to talk about the pediatric cardiac surgeons? So many of them, they come to Punjab, mostly to the Lahore, because Lahore is the capital of Punjab.
And they come to India also, Bangalore and Delhi.
Yes. Many of them go to India, especially for the complex cardiac problem, in which there are multiple cardiac defects. So they have to go to India because it's the closest and the cheapest one as compared to the rest of the world. And in our setup in University of Lahore, I'm working in University of Lahore, University College of Medicine and Dentistry, affiliated to the university. It is one of the biggest private sector universities in Punjab, and second one in the Pakistan. So we have pediatric PCHF, that is pediatric cardiac hospital. It is basically run by an NGO, and we are doing these device closures of ASD, VSD, and many other types of relatively I should say, relatively milder type of diseases, we are doing in our setup as well. And almost more than 500 procedures have been done in the last 2 years. So that's the scenario in Pakistan. But again, I would say, as I'm also a supervisor, so for the postgraduate trainees, we have to teach them to pick up, because many a times a child comes in the OPD and they just, if the patients or the parents say that he has sore throat or any other illness, they just check it and then send the patient away without doing, at least they have to auscultate the heart to pick up this
Correct.
illness.
Absolutely, absolutely.
Malnourished children are there. They are asymptomatic, otherwise maybe having small problems like repeated infections, but not in the ASD case, very rarely in the ASD case. So that's why we teach, and we are trying to teach our undergrads as well as postgrads to, at least during a well baby examination or a simple upper respiratory or diarrhea patient, at least do a check or auscultate the heart. You may pick up, pick up ASD.
Yes.
So thank you so much.
Ma'am,
you
have made a very valid points, and thank you very much for raising that. Probably this was the same case 25 years ago when I started the pediatric cardiology in South India. So what I did was, the first thing in the Cardiological Society of India, I gave the guidelines for starting the pediatric cardiology in the whole country. So now we have a DNB course, we have fellowship course, and hundreds of them are trained all over. So the scene has totally changed now.
Thank you very much, Professor Lakshmi. Really, it was a nice lecture from you, and really a revision for us. As a pathologist, I can ask one question. Is there any material issues that can create the clot or other thromboembolism problem? Is depends upon the material used in the balloon or something else?
That's a very important question. As a pathologist, you know that what is called as the Virchow's law. You have to have three things for the thrombus to occur. Either the stasis, or damage to the endothelium, or there has to be hypercoagulability. So here we take care of everything, and the device as such does not cause. And if the patient has got hypercoagulability, we always, as a precautionary measure, before 24 hours, we start the aspirin, and then after for 3 months, we give the aspirin until the endothelium grows.
And thank you very much. One other suggestion is that, because now the world is globalized and the use of IT and e-techniques, I will suggest as a teacher that as the Dr. Batul Naqvi has told, that there are very few pediatric cardiologists, especially in our country, Pakistan. Can we start all these courses online, and can we start to create the more awareness even in the children, because the early diagnosis can save the patients?
Yes, sir. That's a very important thing. See, what Bangladesh is doing now is, they come here, get trained by us, and they call us every year. And they honored me as a teacher of teachers, because I have taught lots of people there and trained them. So when one of the patients came to Mumbai, my classmate said, Vijayalakshmi, can you do it? So when I went to Dhaka for the conference, I called the lady who is doing the ASD closure, and I asked her to do it. And then this is how we know we had one family, like Vasudhaiva Kutumbakam, and the patients are God to us. For that, we have to do the best. So we all have to work together to give the better quality of life to the children.
Thank you so much. Thank you so much.
I think I would like to wind up the session now, in the interest of time for the speaker and people from different time zones. I would love to invite you on this forum again, ma'am. I think it is a very important topic, and your field is something which I think a lot of general public will also would like to have a lot of questions apart from doctors. So I really thank you for your valuable time. And
Dr. Sarab, Brother Sarab, can I ask a question? Can you talk on webinar in any of the Pakistani webinar if we invite you?
Sure, sir. It's my pleasure.
will
Because that's the
contact-
only country where I have not gone, so I have to.
Thank you so much. Thank you so
It's my pleasure
so
to speak. Yeah.
Thanks.
so thank you so much for joining in, ma'am. And with folded hands, we thank you for joining this forum and enlightening us. Thank you so much. I also thank everyone over here who joined, and all the people who are looking at the questions. If anybody has questions for ma'am, just email me or ask me, and I will be happy to answer that questions by forwarding it to her. Thank you so much for joining, and see you again next week.
Have a great day, all of you. All the best for your profession and the personal life. Thank you.
Thank you. Thank
so
you.
much. Thank you. Allah Hafiz.
Thank you, Saurabh. Happy Dasara.
Thank you. Same to you.
Thank you. Okay, see you next week.